Good day everybody. This is a lecture on SARS-CoV-2 infection, or if you have the disease called COVID-19 disease. So let me start off and tell you that 15,000 before Christ, this is how we lived. We were actually hunting for our food. But then what happened is that we discovered farming. And as we discovered farming, we were living next to animals. And that is very important because I'm going to show you where COVID disease is coming from. So the next step is this, where this is the way that we live these days. And it's overcrowding, and at the moment, we're more than 7 billion people on the planet. Now, the origin of zoonotic diseases is exactly what I explained now. So when we became so many people, we couldn't actually just hunt for our food. And what happened was that we need to have farms. Having farms is living next to animals. And that is the easiest way in which you can actually get animal diseases. Now, it's important to notice that what we see is that 3 out of 4 emerging diseases at the moment is basically zoonotic diseases. Interesting fact is that there was a pandemic in 1889, and in 1960 they looked back and they tried to find the origin of the virus because it was thought always that this was influenza. And what it came out, that it was one of the coronaviruses that is actually rotating at the moment every season in our winter. So thinking back, this might be the future of COVID-19 or the SARS-CoV-2. That is what will happen. It will become a normal cold in a few years from now. Now, there are 7 kinds of viruses or coronaviruses that infect man. And what we see is there are natural hosts, there are intermediate hosts, and then the human. What is important about the last SARS-CoV-2 is that you can see all of these origin viruses basically from bats. The one that we have at the moment with SARS-CoV-2 is the bat COVID virus RATG13, and that's quite important because it's a specific bat that they found in China. And after much thinking about this, they actually decided that the pangolin was the intermediate host to the human. Now, what we see here is the phylogenetic tree of SARS-like origin. And what we see here is the bat, and the RATG13 is around about 90.56% the same. And if I look at the Malayan pangolin, it is 91.02% of the coronavirus that was found in them is similar to what we are finding in SARS-CoV-2 in COVID-19 infection. So giving us the impression that this is where it was actually started, and then the Malayan pangolin is actually the animal that is the intermediate host. Let me change a bit of gears and talk about drivers of infectious diseases. Now, as you can see here, we start with legislation, the systems of government, war and famine, technology and innovation, economic factors, and human activities and social pressures. These things form disease sources and then disease pathways. And of course, what we see, the outbreaks, is actually these things that I discussed now was the drivers of infectious diseases and still is now. So in this picture that you are seeing now at the moment, you are seeing yellow dots flying all over the world map. And what it is aeroplane at any time in the air. There's something very important to notice here. You have to look at Asia, you have to look at Europe, and you have to look at America. Then compare that to the amount of airplanes that's actually coming down into Africa, and it's very small. So what you're seeing here is that it has always been said, a disease will spread as fast as we can fly at the moment. And it is important that when we look at outbreaks, it can be all over the globe in about a week. So clearly what we see is that aeroplanes is one of the main methods in which infectious diseases can spread. If I'm going to go to the next slide, this is human activities and social pressures. Now, this is an interesting slide that was taken in South Africa about 2 weeks ago from now. And what we saw was that you see that the social distancing is not a good concept in South Africa. This is during the lockdown, and clearly what is happening is that there are no social distancing. No one is actually having any protection over their mouths or noses, and it is important to notice that this is one of the drivers of infectious diseases, especially of the COVID. Now, in this slide, what you see here, it's basically the chain or the spread of all infections. You always start with a causative agent, pathogenic organisms. It then goes to reservoir of the source, the means of exit out of that source, okay? And then what we have, the mode of transmission or the method of spread, which is important, and we'll speak a little bit about that later. The portal of entry or the way into the body of then the new person or organism that will be infected, and then who are at risk. Because when you have infectious diseases, it's important to notice that not everyone will get the infection, and that's important that we talk about it. So in this next slide, what I'm showing is the transmission methods. Now, what we see here, it always starts off with the One Health triad. It has to do with humans, animals, and plants. Then you can either have direct spread or you can have indirect spread. If I talk about indirect spread, we talk about droplet spread, fomite spread, airborne spread, and vehicle-borne spread of diseases. What you then see is who are the people that will be infected. And it's the very young, it's the very old, and of course the healthcare workers. So that is important that we realize that in this job of ours, we are in the first line of people that will be infected. And I'll speak about how can we control that we do not get ill. This is the first way in which it is spread, and what it says here is droplet nuclei versus airborne spread. Now, when we talk, what is happening is small particles are coming from our mouths. It's only not talking, but what we also see is coughing, sneezing, and even if you sleep, these particles are coming from your mouth. They are in various sizes. And if you look at the graph on your right-hand side, you will see that I've marked there the sizes 1 to 5 micron. But there are huge amounts of other particle sizes also that is very important. If the particle size is big, and we talk anything about more than 100 microns, what we see here is these small droplets will fall from your mouth. And as they drop down, they actually can fall at your feet. And here I'm showing that around about 5.9 seconds before they hit the area in front of you, right in front of your feet. But on the other side, if these particles are 1 micron in size, what will happen is that they will stay in the air up to 7.9 hours. These small particles is usually what we call the droplet nuclei. And in my head, what I think is that then we must also talk about droplet nuclei and airborne spread as basically exactly the same thing. So it is important to realize that these small particles, as they fall from your mouth, they will lose basically their water, and what will happen is that they will then get lighter and move into the air. And again, it will be inhaled. Then what we see here is that the last thing is that if I sneeze, I can sneeze a particle up to 6 meters far. If it gets into this jet stream, what is happening is that it's projected very far. And that is very, very important for the transmission of certain diseases. This is then just a graph to show you the likelihood of transmission. If I stand next to a person that is breathing out these small particles, and in these small particles there are viruses or other bacteria, then what can happen is your chance of getting disease is extremely easy. But the further that you're away from the person that is exhaling, you can see that there's a decreasing chance of actually getting infected. So the next thing is, what about these small particles that falls from the ground? They actually fall on the floor in front of you, they're on the tables, and what we see here is that the question is, how long will these particles actually last on surfaces? And what we see here is that as an aerosol, up to 3 hours, on copper, up to 4 hours, on cardboard up to 24 hours, on plastic 2 to 3 days, on stainless steel 2 to 3 days. Of course, one thing that is not mentioned here is basically how many viruses are we talking about. So the viral load is very important. And then what we see is that we also have the particles that is lying there and the temperature around them. I do think that is very important, that we realize all these factors will actually influence how long these particles will stay in the air. So now that we know how long the virus lives on surfaces, let's move on to fomite-borne. Now, fomite-borne transmission refers to the inanimate objects such as handkerchiefs, bed linen, towels, books, spoons, forks, and things like this. And it is extremely important that one realize that around the COVID-19 patient, the whole area is contaminated with the virus. On your left-hand side, you can actually see in an ICU setting where you will find the most commonest areas in which the virus will be. On the right-hand side, what you see is that I've put here 6 different solutions that you can use to actually clean the surfaces. Of course, not all of them is appropriate. What we see here is you can use ethanol. 70% is good enough. It is also been said if it's 95% and higher, the time that it takes to lower the amount of viruses is very important. Then we talk about propanol, we talk about glutaraldehyde and formaldehyde, which is usually not used because they're too toxic, and then povidone iodine. Of course, that is also not often used. And then perhaps the best one of these is sodium hypochlorite. But what is important here is that the solution must be at least a 0.21% solution. And that's extremely important. What I'm showing you here in this slide is a study that was done when there was an outbreak of SARS. And what happened here was that it was published in 2013. And what they tried to show is that a patient came in. Let's call the patient KN1, and it came into a hospital. In this hospital, what happened is that about 30 healthcare workers got infected. Then they got frightened, and what happened was that they sent the patient basically to hospital 2. And then what we see is that 29 patients got infected. And when they got frightened, they decided to send to the tertiary hospital. The tertiary hospital was warned. Listen, this organism is airborne. This organism is lying on the floors. It's lying everywhere. And you can clearly see that if you take proper precautions, what we see, 0 people was infected in the hospital. And that is what we are aiming for, to make sure that nobody is actually getting infected in the hospital with the proper gear. Now, what you see here is a very important slide. You see on the left-hand side, it says, the doctor who alerted the world to virus dies from it. And what you see here is the doctor from Wuhan, and what he actually did is he told people about the virus that is coming. And what we see here is that the infection, his infection most probably came from the wrong use of his PPE. Because clearly what is happening here, if you look at this slide, you can see that he is wearing basically his surgical mask under his N95 respirator. Now, this is not a good plan. You always put your respirator on your skin for a tight fit. Never put this underneath. You are allowed to put it over to protect the surface, but you are not allowed to do this, because then you never have a seal. And I think, if I look at this picture, this is perhaps the reason why he got infected. Now, these respirators is devices. These devices is very specific. You must treat them with care, because they are the only thing that's standing between you and infection. And what you're seeing here is that they're actually not filtering. What they're doing is that they have impaction, interception, diffusion, and electrostatic attraction as the way in which they filter out these small particles. So they are particulate filters. If you look at this photo at the bottom on the right-hand side, what you're seeing is this is a picture of people that went through a coal dust test. Now, the coal dust test was always done when people had to work in the mines, and then they had to look at seal. And what we are doing is that we do fit testing to make sure that the sealing of your respirator is proper. In this case, you can see that the person in the middle has a very good fit, no leakage. But both on the left-hand side and the right-hand side, you can clearly see where these people leaked. And that is important because if it contains a virus instead of coal dust, what will happen is that you will get infected. So, the bottom line of this is masks are for patients. So when they are actually coming into the hospital, always put a mask on them. These small particles that's coming from their mouth, you need to make sure that when they are exhaling them, the big particles do not fall basically in front of him on the surfaces. But what we also know is that a normal surgical mask or even a cotton mask will not stop the small particles. We have done studies actually to show that when we work with tuberculosis, about 50% of the particles that's very small will come through a normal surgical mask. So do not think that you are protected by a normal surgical mask. Respirators are for healthcare workers. I do not want any one of the students or any one of my staff that is working with COVID-19 patients to ever wear a normal surgical mask because I do not believe in it. We have tested them and they fail within the first second. Okay, so fit testing is essential, respirators for healthcare workers, masks for patients, and then the important thing, when you take off your respirator, there is a specific way in which you must do. So doffing of your PPE, doffing of your respirator is a very important part of infection control. And we will show you later how to do this, not get infected. In this slide, what I'm showing you is that it's a model that there's an outbreak in the country, and what you see here is the amount of people, and there was only 199 people, and one person that was ill, and how fast it actually took to infect all of these people over a time. In this model, no one died, and in this model, what we see is that 200 recovered. So it is not COVID-19, but what it shows you is that if you look at the peak, you can clearly see what happened to it. In the next slide, I'm going to put the model on again. And what you must look at is that we are in lockdown. As soon as I open this lockdown, what will happen? And of course, that is exactly where we are. So here it opens. Clearly what happens is there is no stopping of this infection. And it just takes a little bit longer because now you can look at the graph and you can see that this graph has flattened. So why do we need to flatten the graph? And I will explain to you this. If you look at the Warplan says, I need to contain, I need to delay, and I need to mitigate. So what it says that if I do no measures, you can clearly see in this graph on the left-hand side, without measurements, what you see is there's a line that says that is where the healthcare system capacity lies. Anything over that is that when people are coming in and they're overburdening the system, what will happen is most of those people will die because there is no help for them. So what we are also trying to do with the lockdown is to make sure that I can lower the curve. And you can see with the measurements, perhaps there was the same amount of infections, but it was over a longer time. What is also important here is that you can see that the peak is later, started slower. And what happens here is that I did have time to prepare myself. And that's exactly what we are doing at the moment. So we are preparing for this outbreak and trying to keep it under that line where we cannot cope with the amount of infections that we're seeing here. If we don't do it, there will be consequences that a lot of people cannot be helped. Of course, the one that I didn't put in here is the research. Between contained, delay, you can see actually just delay and mitigate, what you find is that there must be some research because we need to find out how to stop the virus. And there are several ways in which we can do it. In this slide, what I'm just trying to show you is the difference between the influenza A COVID-19, SARS, and MERS. And there's just a few points that I want to show here. If I look at the basic reproduction number, that is one person infected will infect how many others? And we see influenza is 1.3 here, and that is usually, if it's rotating in the season, we can see is that around about 2% of people will get into the hospital that's infected, but there's more than 1 billion people that actually gets globally infected every year. Okay, so more than 1 billion. But we can also see that the amount of people that die is much lower. So if we look then at COVID-19, what we see is at the moment we still think perhaps that the basic reproductive number is about 2.5, which I'm not convinced it's true, because we are not keeping in mind that up to 40% of people is asymptomatic. We're not counting these people usually when we work out this R0 number, but we should. And what is important about it is that it is actually perhaps the basic reproductive number is much higher. The R0 is around about 10 perhaps, as high as that, but we do not understand it yet. What we also see here is something that's called the case fatality rate. Now, what I told you about influenza is that you can see 0.1% is case fatalities, people who die from the disease. At the moment, in South Africa, and I'll show you later, we have around about 1.9% of people who get infected will die. What we see for SARS, it was 11%, and then for MERS, it was 54%. And then you can see also the incubation time. Now, we still think that COVID-19 disease is between 4 days and basically 14 days of incubation. And that's an important slide, this to actually explain what will happen. So this was a very important slide to actually talk about the comparison between different respiratory virus infections. The data, or the slide that I'm showing you here, is from this morning. And what we can see is that we, from this morning, have 4,177,584 cases, of which more than 200,000 people have died. If I go to Africa, we see that it's increasing, and what we are seeing is that South Africa is the front runner, and perhaps in this next slide I can show you that we have now more than 10,015 cases, and what we see 194 deaths. So this is important, that we can clearly see that the disease is fast moving also in Africa and also in South Africa. So here is the final one to show you, 10,652, and what we see 1.93% deaths. And it's important to realize that this is actually quite a low number. We are expecting this to actually go up. As we are getting more and more cases, what will happen is that we will not be able to help everybody. So let's move on, and we talk about the entry of this virus, the SARS-CoV-2. Now, interesting enough, we know now that it comes from the bat. We now know that there is a pangolin that has given it to humans. And then what happens is the virus will enter into the body. And what we'll see is viral attachment and fusion begins with the interaction of a specific interaction between the spike protein of the virus and basically the ACE2 receptor. But what is also important in this slide is to see that in this right bottom picture here, what you're finding is that it's a specific binding, and because it's not 100%, you actually need something that must help the binding, and that is a proteolytic cleavage by cellular proteases. Okay, so there is something needed to actually help the virus to enter into the cell. Now this is an extremely busy slide. I will break it down a little bit, but what I was talking about in the previous slide is basically how do I get my infection, and what you see here is basically the pathogenesis. Now, what you're seeing here is through fecal material. We know that the virus is also present in stool, and we know through respiratory droplets that you can inhale in. It gets into the lung, and then what is happening is that there's the entry on your right hand side. You can see the entry into the lungs. there's the ACE2 receptor. Then what is happening is that the machinery of the cell helps actually the virus to divide. And what is happening with proteases, it makes new viruses, and they actually exit the pneumocyte 2 cell. Now, I'm going to go to the next slide, and what is important about this is to show you exactly what is happening in the lung. And what you see here is that when the virus actually goes into the pneumocyte 2, the alveoli is infected. This alveoli, what it does is that it actually brings out quite a lot of different cytokines. And what we see here is interleukin 1, interleukin 6, TNF-alpha are the important ones. Now, I'll show you in the next slide how does it exactly happen. But what it does, it attracts different kinds of cells like your neutrophils and also other cells. And the end product of this is a alveoli that is filled with liquids, with cells. And of course, the alveoli, and what you see here is the blood vessel, they cannot exchange gas anymore. And what is happening is that there's no breathing actually taking place. Diffusion between the alveoli and the artery cannot take place. And what you see here is basically increased work of breathing and the fluid accumulation. What will happen then is that there's also stimulation of the brain. And what we have here is then a total effect that breathing actually cannot take place. And what we see, hypoxemia actually happens. If I look at the symptoms, this is a very busy slide, but what I want to show you is that you mustn't think that if there is something like allergies on the line, cold, influenza, and COVID-19, that you can clearly distinguish between them. I have shown on this last piece of the graph here on your right-hand side, the most commonest things that you will find is the fever. Having said that, be very careful with fever. In Wuhan, in articles, it showed that only 44% of the people entering into the hospital actually had fever. It's only later on that 88% developed fever. In a study from New York, it showed that only 51% of people, when they entered into the hospital, had fever. So one mustn't put all your cards on the fever, because that is not what's happening all over the world. But then what you see here is the dry cough, the fatigue, and also then exposure is a very important part of thinking about COVID. And what is important about this is that you can see that the sore throats are there, the shortness of breath if it becomes severe disease. Of course, there's other things like diarrhea, and basically any organ that contains ACE2 receptors can give you symptoms. And so it is actually very difficult sometimes to know that this is COVID infection. At the moment in the hospital, before I allow you into the hospital, I do make sure that you are not infected, and therefore the only way to do that is to do a smear from your throat and nasopharynx to make sure that you are not infected. But having said that, it is also not 100%. We think that the test is not more than about 75% accurate, so sensitive and specific. This is perhaps the most important slide. It is the association between coagulation and inflammation. And what you're seeing here is that what is happening on cellular level. And what you see here is the monocyte, all right? And what is happening is that once you have an infection, what happens is that you have the DAMs, that's the damaging changes or associated proteins that you have. You have your reactive oxygen intermediates, your LPSs and your TNF. It stimulates the macrophage or the monocyte. What then happens is that there are tissue factor that is secreted. We think that the tissue factor is the spilling point of the whole cascade that follows between coagulation and inflammation. Now they are recognized on toll-like receptors, and to make a long story short, the cells that are involved here is the monocyte, the endothelial cells, and the smooth muscle cells. And you can see this whole cascade here. The important thing about it is that you can see that when I stimulate these cells, factor 7A, 10A, and 9A leads to activation of 2A, which then stimulate basically the endothelial cells to have von Willebrand factors, CD62, and what these cells does is that under the stimulation of all the pro-inflammatory cytokines like interleukin 6, interleukin 8, TNF-alpha and interleukin 1, what will happen is that they actually attract all the different cells to the alveoli. And that is where it happens. But there's more than that. There are microparticles that we know now that is actually forming from the different cells, like the monocytes, okay? They contain different stimulants and also interleukins, and that will lead to what you see here is called nets. So netosis is something that happens when a neutrophil actually secretes some DNA, and what happens is that there are nets forming to actually catch the different viruses and things. On the other side, on your right-hand side here, platelets are extremely important. And what you see here, once again, these microparticles stimulates different cells, also the platelets. And what we see here is that the complement system are activated. All of this leads to one thing. It leads to a cytokine storm that I will describe soon. And what you see here is then also clotting that is actually happening. Now, it's interesting that we think that the amount of clotting that is going on during severe disease is perhaps one of the biggest factors why people die. Now, the comorbidities and mortality that you're seeing on this slide, on the left side, what you see here is the leading comorbidities at the moment, and this was a study done in New York. Hypertension, diabetes, hyperlipidemia, and what we see here is coronary artery diseases. Now, all of these things that is mentioned here actually have an increase in the chance of actually dying from COVID-19. And then if you look on the right side here is the leading countries where people were dying. And what is interesting is that Italy is on top. Okay, and what you see here is that Italy has a case fatality rate of almost 8% compared to the rest of the world, okay? And if I look at the Norway, which is 0.21%, there's a huge difference. But what we know is that it has to do with a few factors. It has to do with the type of clade of the virus that is present. It has to do with the genetics of the country. It has to do with the age and the comorbidities. In Italy, it was found that the people who died, 50% of them actually had 3 or more comorbidities, and that is a very important factor. So they are also a very old country where most of the people who died was basically over 70 years old. In this slide, I'm talking about proposed treatments. Now, I'm not going to go into detail on all of this. I will discuss about 4 of them, and I will talk about other things that we do. But this is a very nice picture to actually show you where are we trying to stop the virus. So let me go on first and talk about hydroxychloroquine. Now, interesting, hydroxychloroquine is a drug that is now being used and in this first studies, which was done in France, we saw here that when they tried to look at how fast can I clear the virus, and this is on day 6, 70% of people cleared it if they were using hydroxychloroquine. Compare this to people who didn't have hydroxychloroquine, and we can see here that it took much longer. So 12% of people could only clear it by day 6. So if I would add other antibiotics, azithromycin, what happened was only 6 of these people were also given azithromycin. 100%, then 6 out of 6, cleared basically the virus within 6 days. The method in which hydroxychloroquine works is basically it blocks the viral entry into cells, okay? The glycosylation of the host receptors, proteolytic processing, and endosomal acidification. So what is happening is that the virus inside the endosomes do not acidify and they cannot come out because they are blocked. There's also some immunomodulating effects through attenuation of cytokine productions and inhibition of the autophagy of these lysosomes that I talked about. This is the next slide that shows basically what effect did we see with lopinavir, ritonavir. And what we see here on the right side is that in this study, you can see that there was basically no difference between using lopinavir, ritonavir and the controls. So at the moment, using lopinavir, ritonavir, we're not convinced that it makes a difference. There was a paper that came out last night that actually showed lopinavir, ritonavir combined with 2 other drugs may make a difference, but at this stage what we know is by using it alone, so that is a protease inhibitor, it didn't make any difference in blocking the virus from coming out of the cells or stopping infection. Ribavirin is one of the drugs that you have seen in that picture, but what we see here, to make it short, it was supposed to increase the interference. It was supposed to actually make sure that mitogenesis is actually blocked. And what we see here is that in previous studies that was done on SARS, 26 out of 50 studies actually showed no difference, and in 4 of these studies it was seen that there can be harm. So at the moment, I do not see a place for ribavirin in the use of SARS-CoV-2 or COVID-19 infection. Remdesivir is the next slide, and what we see here is that it was a drug that we thought will make a huge difference. It's an antiviral, but if you have a look, you can clearly see here that it didn't make a difference on the slide on the right hand side top, and what you see here, outcomes didn't differ. If we look at the bottom slide or the area, what we see here is that the reduction in the amount of the viruses with remdesivir didn't make any difference, and it was really a bad shock to us to actually see in this study that we couldn't use this drug effectively. Perhaps in other studies we will see something different, but what we see in this study that came out, there was not much difference. I want to go now to interleukin-6 inhibitors. Now, this is something that is used in specific patients when they have a high interleukin-6, and what we know is this might be the driver of the whole cytokine profile. So let's start. Here's the coronavirus. On top, it goes down, it can go into macrophages, dendritic cells, monocytes. And what you see here is once these cells are activated, there are pro-inflammatory cytokines that is actually coming from it. The main one is interleukin-6. And what we see here is that that interleukin-6 can bind in 2 ways onto the interleukin-6 receptor. It can be in a signaling way, which it's already on the membrane, or it can be in solution, it's soluble, and then after binding, it will bind onto the cell membrane, and that is called trans-signaling. Once that happens, you can clearly see there's a huge cytokine release syndrome that happens. Now, in this picture here, you can actually see there are 2 interleukin-6 inhibitors that is used to actually block the whole process. But I will show you now. This is the end of what is happening during a cytokine release storm. And what you see here is there are lymphocyte changes, blood vessel changes, and liver changes. And all of this, when it happens, is most probably that it leads mostly to the death of the patient. Just to summarize for you, in this slide, the early stages of infection, you can clearly see that there is a virus coming in to the alveoli. You can see no severe disease there, but when it becomes severe, you can see the amount of different cells that has been attracted into the alveoli, the hyaline membranes that's forming. You can see the fibroblasts, and then clearly what you see is the cytokine storm that is forming the whole process. And what is happening? Exchange of oxygen and CO2 cannot be produced, because what is happening is that everything is blocked. On the right side, what you see here is basically a picture of the role of interleukin-6. I'm not going to go into detail, but you can clearly see that it has got a massive effect on the whole immune system as a pro-inflammatory cytokine. And therefore, when we use interleukin-6 inhibitors, that is a way of stopping this severe stage of disease. In this slide, what you can see here, it is CT scans before and after interleukin-6 inhibitors was used, and you can clearly see there was no progression. It was actually, you can see the disease clearing up in the lungs. What perhaps was more important in this next slide is that you can see the CRP, even after one dose basically, came down. And what happened was that when the CRP came down, the temperature came down. And that is very important because interleukin-6 is also a driver of temperature. More important than that, what we saw here is that the amount of oxygen that you needed, that the patient needed, actually became lower. And what you see here is the saturation went up. So combining all of these slides, it actually shows that in these patients that was given interleukin-6 inhibitors, doxizumab was actually the one that made a difference. I must tell you that we in South Africa have also used interleukin-6 inhibitors, and at this stage we have not seen this great effect that we have seen here. So the last part that I want to discuss is other things that we can use. In this slide, I show you high-dose intravenous vitamin C. And it is very important that in the slide on the right side, you can see the difference basically what we see between vitamin C and placebo. And what it has to do is that it has to do with that neutrophil extracellular traps and those things that happens. And what we see here by using high dose, and if I talk about high dose, I talk about 12 grams of vitamin C infusion for 7 days. That is massive dosages. But the study is ongoing at the moment in China, where they try to see if this amount of high-dose vitamin C will make an outcome in the mortality that we see here in this one slide here. Vitamin D is perhaps one of the most important things that you can take. Most people are actually deficient. Even if we live in a country of that much sunshine, most people actually have a very low vitamin D concentration. And what we see here is the role of vitamin D in COVID-19 is extremely important. It has to do with the effect of antiviral effects. It has to do with lowering the pro-inflammatory cytokines. And what it does is that your chance of dying when I give you proper dosages of vitamin D, it actually seems to help. So when you come in with severe disease, I will treat you with vitamin D. What we see here in the study also that was done, we see that there is a 12% overall protective effect of vitamin D supplementation. What is very important was if you were already on vitamin D, that protective effect went up to 19%, which was very significant. This is my second last slide, and what I'm trying to show here is that it's basically to do with the co-infections with COVID-19. It has been seen that around about 20% of people infected with COVID-19 or have COVID-19 disease, what is happening is that there are a second virus that is actually with this. And the most commonest was basically what you see here, the rhinovirus, enterovirus, RSV, and then other viruses like other coronaviruses, but not the SARS-CoV-2 virus. Now, this is important because I would actually urge everybody to actually get a vaccination with influenza, because it is important that you protect yourself against influenza, because if you get influenza A or B or C, and on top of that, you also get infection with the COVID, your chances of survival is so much lower. So if I can take away the population that's only have got influenza, then I can concentrate on the coronavirus. We know now that it's also not 100% of people will be protected by the vaccination of influenza, but we do know that it makes a difference in the outcome. So this is the last slide, and what it says, it is A Tale of Two Cities by Charles Dickens. And what it says is, it was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. It was the epoch of belief. I truly believe that there are some benefits to the pandemic that we're living in. And the amount of knowledge that we're gaining is perhaps the most important thing that we must take away from this infection.